This is a case of Jefferson and Hangman fractures. In this tutorial video, I will go through the case stem provided to you in the module. I will demonstrate an approach to the interpretation of C-spine radiographs, and we will go through the post-module quiz questions together. A 61-year-old male presented to the emergency department after falling down a flight of stairs. He landed at the bottom head first. X-rays and CT imaging were both acquired. So what's important from this stem here is that the patient fell head first. So when you fall in that manner, it causes an axial force of compression that can lead to a burst fracture of the atlas, also known as a Jefferson fracture. So sometimes in the clinical history that's provided to you, there can be invaluable information that can tell you what to expect. If you don't get much in terms of clinical history, you can always review the clinical note in the patient's file. These were some images that were provided to you. This is an example of an open mouth odontoid view on plain radiography. We can see the mouth is open, and we're attempting to image the entirety of the odontoid process, although it is partially covered by the patient's teeth. And this is an example of an axial CT slice of the cervical spine, and as we can see, the bone window is on, which allows us to focus on the osseous structures here. So, and this is an approach to interpreting C-spine radiographs. I'm using the ABCs mnemonic because it can be helpful for trainees who are new to image interpretation. However, different clinicians or radiologists have different ways of analyzing images. And what's important is that once you've found a search pattern that you like, that you're consistent in your approach and you're systematic. So when you're assessing for alignment, you have to assess on the lateral, AP, and open mouth odontoid projections. And on the lateral view, you can assess the anterior longitudinal line, the posterior longitudinal line, the spinolaminar line, and the posterior spinous line, the atlantodens interval, or ADI, and the basion dens interval, or BDI. On the AP view, you can evaluate the edges of the vertebral bodies and their articular pillars to see if they're aligned, and the spinous processes should all be midline and equidistant between the pedicles. Finally, on the open mouth odontoid view, the occipital condyles should align with the superior articular facets of C1. The dens or odontoid process should be equidistant between the lateral masses of C1, and the tips of the lateral masses should align with the lateral margins of the superior articular facets of C2. Then you would want to trace the outline of each vertebrae. Each body should be rectangular and approximately equal in size. The anterior height should roughly equal the posterior height of the vertebral body, although the posterior aspect of the vertebral body may be slightly taller. Up to 3 millimeters taller is considered to be within acceptable limits. Cartilage, you want to assess the disc spaces, make sure they're uniform in size. And lastly, soft tissue / everything else. What's particularly important with the C-spine is to look for prevertebral soft tissue swelling, especially in the context of trauma like for this patient, because it can be due to hematoma formation secondary to an occult fracture. There are times where on a plain radiograph there may not be evidence of cortical disruption, but prevertebral soft tissue swelling or malalignment can raise your suspicion for a fracture and maybe prompt you to order some cross-sectional imaging for further evaluation. So this is an example of your anterior vertebral line going along the anterior margin of the vertebral bodies. This is your posterior vertebral line. You can see how it's traversing the posterior margin of the vertebral bodies. We have our spinolaminar line traveling down and aligning along the posterior margin of the spinal canal. And then lastly, our fourth line here is the posterior spinous line, going along the tips of the spinous processes. When you're thinking of the atlanto-dens interval, you want to measure the space between the anterior aspect of the odontoid and the posterior aspect of the anterior arch of C1. And for your basion-dens interval, you want to draw a line between the basion and the top of the odontoid process. If any of these are widened, it's indicative of atlanto-occipital dissociation, and that's something that you would not want to miss. And when we're tracing our bony outlines here, we're tracing the vertebral bodies, making sure there's no cortical disruption, making sure they're roughly equal in size. You also want to assess the lateral masses, make sure the facet joints are normal in their configuration and patent, assessing the lamina and the pedicles, and lastly the spinous process. Going through all of these osseous structures and looking for any signs of fracture. You can also assess for these things, as mentioned before, on the AP and open mouth odontoid views. So as I mentioned, the spinous processes on the AP view should be running down the midline, and they should be equidistant from the pedicles here. So if you can appreciate that all this structure together can resemble an owl, and sometimes you call the pedicles owl eyes, and then you have the spinous process here in the middle. That could represent a beak. Again, you would want to trace the cortical outline, assess the intervertebral disc spaces to make sure they're uniform, pay particular attention on the AP projection of the transverse processes of the cervical spine. Fractures for this region can be clinically important for reasons that we will talk about later. And again, the odontoid process should be equidistant between the lateral masses of C1, and the lateral masses of C1 should be in alignment with the superior articular facet of C2. It's difficult to appreciate because this image is perhaps a bit overexposed, but if you can adjust your window settings, you would be able to follow the C2 superior articular process to make sure that everything's in line with the blue here. Next, assessing the soft tissue spaces, we have the nasopharyngeal space, the retropharyngeal space, and the retrotracheal space. And all of these have different measurement cutoffs in terms of what is normal for both pediatric and adult patients. And once again, if we see any sign of prevertebral soft tissue swelling, this can be a sign of occult fracture and hematoma formation. This brings us to question 1. What is the primary abnormality seen on the open mouth odontoid view? And if we assess our alignment here, we can see that the odontoid process is not equidistant between these lateral masses of C1. And additionally, if we trace the lateral margin of the lateral mass of C1, it is not in proper alignment with the superior articular facet of C2. So what we know is that the lateral masses of C1 have now laterally shifted. We cannot appreciate any fracture of the odontoid or the body of C2, so based on this question, this is not correct. And D is incorrect because it's not the lateral masses of C2 or the axis that have shifted. It's the lateral masses of C1 or the atlas that have laterally shifted. And what that corresponds to is ligamentous injury. So we have disruption of these important ligaments here, resulting in lateral shifting of the lateral masses of C1. And if we take this coronal view and we look at it from an axial perspective, this is when you can start to see what we see over here. So evidence of a Jefferson fracture or a burst fracture of the atlas or C1. So we have cortical disruptions in the anterior and posterior arches that are surrounding the odontoid process. Tomographically, we can see here the tip of the odontoid, and we're seeing the anterior arch of C1 with these cortical disruptions. And this was from the imaging file provided to you in the case. So again, lateral shifting of the lateral masses. It's not in alignment with the superior articular process of C2. When you flip it on its axial, it can be indicative of cortical disruptions here, which we can appreciate on CT. The second question is, what is the name of the fracture identified in imaging? So as previously discussed, it's a Jefferson fracture, which is a burst fracture of the atlas, not a burst fracture of the axis, which is C2. What we saw is not consistent with a Hangman fracture, which we'll talk about in a little bit. That involves bilateral fractures of the pars interarticularis of C2. Additionally, C, seatbelt sign, is not correct. This is either a physical exam finding consistent with bruising over the areas in which the patient typically wears a seatbelt in an MVA. And radiographically, you might see subcutaneous bruising, and that can lead you to look for further pathologies in the abdomen, chest, and sometimes the neck based on how the patient was wearing the seatbelt. Question 3. What is a Hangman fracture? A Hangman fracture involves bilateral fractures of the pars interarticularis of C2. And the rest of these answers are not correct because it does not match the eponym provided here in the question stem. This is a diagram example of what you can find with a Hangman's fracture. So again, we're seeing C2 or axis pars interarticularis fractures or cortical disruption. We're seeing anterior dislocation of the C2 vertebral body, and we're seeing prevertebral soft tissue swelling. And corresponding to that, there is a little bit of cortical disruption in this region, outlined by the red arrow. We can see that there is anterior dislocation of the C2 vertebral body and widening of this prevertebral space here. Now it can be difficult to appreciate the bilateral pars interarticularis fractures on plain radiographs at times because there can be overlapping structures, and the orientation of different structures can change based on how the technologist positions the patient. So this is where assessing the alignment and the soft tissues is important. If you did not see this here, you might notice this anterior dislocation and this soft tissue swelling, and that could prompt you to order a CT scan for further evaluation, in which the findings can become more obvious. So now we're seeing a more obvious linear lucent line on the sagittal view through the pars interarticularis of C2, and this is what it corresponds to on axial imaging. Notice that the bone windows are utilized for ease of evaluation of osseous structures. Lastly, if imaging demonstrated a fracture of the left transverse foramen of C4, what vascular injury would this raise concern for? And the answer is the left vertebral artery, and this has to do with knowing your anatomy. So the vertebral arteries will branch from the subclavian artery, and they will enter the transverse foramen, usually of C6, ascend up the neck, and eventually exit through a transverse foramen so that they can then traverse intracranially through the foramen magnum. And since the left vertebral artery is what lies within the transverse foramina of the cervical spine, you could see how if there was a fracture, we'll show the diagram here of this, that there is a possibility that a fracture fragment could become displaced and cause a laceration of the vertebral arteries. Again, we see it coming off the subclavian artery, going into these transverse foramina, exiting and ascending up into the cranium via the foramen magnum, and both these vertebral arteries will join to form the basilar artery, which subsequently will branch off and supply the posterior circulation. This concludes our case on Jefferson and Hangman fractures.